Hello and welcome to Vane University Grand Rounds. We meet every Wednesday at 12. I'm your host, Lowell Kadnick, and it gives me great pleasure to introduce Alan Davis, who's going to be talking today on superficial venous ablation and when to use where, and our discussants, Michael Sadek and Alvaro Arrego. The floor is yours, Alan.
Lowell, thank you very much. It's a great pleasure to talk on this topic about superficial venous ablation, when to use and where. Sorry. As you know, there are many different treatment options for truncal ablation, ranging from surgery, radiofrequency, glue, laser, and sclerotherapy. But the first question we need to ask is, who should we actually be treating? And obviously this will be a different issue globally. But actually, if you look at most of the international guidelines, they do agree with the original NICE guidance that the people who should be treated are the same as those people who are referred to a vascular service, i.e. people with bleeding varicose veins, symptomatic primary or asymptomatic veins, those with skin change, those who've had a superficial vein thrombosis, people with either a healed or a non-healed venous leg ulcer. And I really don't think there's anything controversial there. I'm not going to talk about the role of ablation in cosmesis, but certainly for symptomatic varicose veins, it is a very clear decision. Now, there are probably as many different techniques or ways of doing it as there are people listening to this talk. But it is also clearly to say that for truncal ablation, the statements made by NICE are very similar to those of the others, that basically endothermal ablation is the first recommendation. And I apologize for those slides moving forward. But the one key thing I would like to highlight is this: do not use compression hosiery to treat varicose veins unless an interventional treatment is not suitable. Here are the NICE and ESVS and American Venous Forum guidelines highlighted, and they really do confirm what I've said with respect to endothermal ablation. But one of the big questions I'd like to highlight to you is what we do with the below knee GSV segment. Yes, there is agreement that we should ablate at the lowest point of reflux. This often does not happen. And there's an overall view that non-thermal techniques may be better with respect to this cohort for the obvious reasons to avoid thermal injury. If we look at the European College guidelines, there's a very clear 1A recommendation for radiofrequency ablation for both the great and the short saphenous veins, but the role of MOCA and cyanoacrylate are both 2B and 2A class recommendations. So something for us to think about. So what are we actually looking at with respect to the success of our ablation? Are we looking at closure rates, relief of symptoms, recurrent rates, patient acceptability, cost, re-intervention rates, or what are the complications? And there will be those of you who will regard the outcomes of studies and what is important to you, and it may be different in your own health jurisdiction. I would like to flag the Venous Seal Spectrum study, which is a multi-million-dollar study that has been organized by Medtronic, looking at randomized control trials comparing thermal ablation with surgery with glue, and then a cohort study just looking at glue. Now, this is some of the initial 6 months data, but the straightforward answer, certainly comparing with thermal ablation to venous seal, there was certainly no evidence of any benefit of the venous seal over the endothermal ablation. And yes, there was undoubtedly patient preference with respect to venous seal with respect to surgical stripping. But the longer term results of this are still due. And when we actually look at the evidence, the short saphenous vein is a little bit of a Cinderella with respect to the evidence. And I'm going to rely on some of the evidence from really now a quite old Cochrane review to suggest that there was evidence to suggest that endothermal ablation is probably better than surgical repair. The only thing that one should really think about is that there may be more evidence that you get a higher rate of deep vein thrombosis in those people who are having short saphenous vein ablation. If we then look at the various techniques, the maximum diameters and the IFU, this chart just shows a rule of thumb that I would suggest that may be worthwhile considering, is that you can obviously offer surgery in any form of patient. Laser and radiofrequency, yes, you can certainly go up to 2 centimeters. You can go more depending on how effective you are with respect to your tumescence. Mocha and glue probably you might suggest should be used for smaller veins, similarly to the use of foam. If we look at the outcomes from all of the studies looking at quality of life and outcome occlusion, radiofrequency and laser are about the same. Foam is undoubtedly worse with respect to longer-term occlusion rates. In the longer term, surgery undoubtedly gives the same quality of improvement in the longer term and the same occlusion rates. And depending on the studies that you look at, there are certainly good occlusion rates for mocha and glue, but I would accept some of the later studies do suggest that there may be a slightly poorer occlusion rate with mocha, but if you look at the quality of life improvements, they are all very similar. Now, this is a patient who has had some clinical staining after having had an extrafascial GSV treated, and this may well be a standard picture from somebody having glue, foam, or mocha. So it is just something to think about. If we look at all the treatments, they all have comparative pitfalls, and this is just a summation and does reflect many of my own biases. Yes, there is undoubtedly probably more post-operative pain with surgery. It's done usually under general anesthesia, but we should acknowledge that in the modern day, it is something that you can do under local and tumescence. But again, here it summarizes some of the key complications. All of them are associated with complications such as VTE. There is undoubtedly evidence of nerve damage and skin damage in all, and all are associated with long-term recurrence. And I'll comment a little bit about that more later. These are my absolute biases with respect to the anatomy that we are treating. If it is an above-knee GSV, certainly for me, the first choice is endothermal, probably followed by surgery, then glue, then mocha and foam. If it is a above-knee extrafascial, my own particular preference is to do phlebectomy, with foam being possibly a second choice. For the below-knee GSV segment, I would put all three of the non-thermal technologies there as probably being an equal choice. For the short saphenous vein, I would suggest that you should think about using an endothermal approach first, followed by foam and mocha. A third choice would be glue, and it is important to note that glue actually on the IFU with respect to the Safion or the Medtronic glue, it is in inverted commas not licensed for it, and then surgery would be next. My own bias with respect to tributaries that we've not really discussed is actually phlebectomy and foam as a secondary option, and recurrences at the junction probably would be foam and then either surgery or endothermal ablation if you have got long segments of truncal vein to treat. Then I would like just to pose you a question. Should we treat or not treat non-refluxing veins? We're probably all well aware of the synchronous study that is being done in Germany. You've also seen the recommendations from the AVLS. The 6-month data from the synchronous study certainly shows that it is safe. It has the similar complication rates to just ablating the truncal vein, but I think it is very much the jury is still out as to are there long-term benefits. and I would suggest we need to watch this space. What is interesting is this study from Ron Bush's group many years ago has suggested that actually if you can ablate the GSV as low as possible in the mid-calf, therefore leaves you with the idea that you should maybe treat the whole of the GSV, you may end up with lower recurrence in the future. This is a study that we did that showed that at 6 months, 19% of below knee segments that had no reflux in at the time of the procedure, within 19 months, they went on to develop incompetence. There are other studies out there that have suggested that if you treat the whole of the GSV, you may have a lower recurrence rate. And it's also worthwhile noticing that whatever technology you use, there is a significant recurrence rate, but the type of recurrence is different. We may all want to argue as to which toy we think is best of our own, but it should be remembered that they are all actually give or take cost effective in comparison to doing nothing, but there is undoubted variation. And at the moment, with the difference in costs with respect to glue, it is probably more expensive than the other technologies, but once it has the same procedural cost, it too will be equally cost effective. We should remember that all patients are different. There are multiple guidelines out there, but not one size fits all. And it is probably true to say that no single technique is perfect. We should undoubtedly individualize things for the individual patient. It may also come down to what cost and what may be approved to be funded. Undoubtedly, I think we would all probably advocate using a non-thermal technique to below the knee. I think there are some cases where traditional surgery may well be best. I think the argument between